I'm saying is that our expensive, inefficient, and non-innovative pharmaceutical model is now coming back against us, especially in times of economic crisis, in parts of the European Union, especially in Eastern Europe and in Southern Europe. Now, I'd like to say that we have been working a lot in Greece. We've organized a number of conferences about the access to medicine crisis in Greece. Last Monday we had a conference in Madrid, in Spain. And we're talking about something that's very real. Many people have categories in their mind where they say, this is a European country, we all have everything covered, no one has any problem. You know, no one is going to go home and just die when they can't get the breast cancer drug, like is happening for many people in Greece. Immigrants aren't going to die waiting outside a hospital, like is happening in Spain. Others are not going to get the medicine that's going to prevent the rejection of a liver transplant because it's not affordable in one region or another in Spain, staying outside. So this is happening inside the European Union. These are zombie categories that we're dealing with. Europe, middle-income countries, like by the World Health Organization, or low-income countries. For example, it's like outside of Europe, you know what the pharmaceutical industry and the World Health Organization considers a middle-income country today? Syria. Syria, for setting prices of medicines or vaccines, a middle-income country. Now, inside the European Union, what does it mean charging prices like this in the middle of an economic crisis that Greece has? With 28% unemployment, 65% youth unemployment, and when you're unemployed for 2 years, what happens? Anyone know what happens when you're unemployed for 2 years and you're a Greek citizen? I'm not even talking about immigrants, or even much worse. What happens? You lose all of your health coverage. You get no health coverage. You're taken off the book, and you cannot get a state prescription, and if you're ill, the only kind of care you can get is an emergency care, like to fix a broken bone like this, and then you're thrown out into the streets again. That's it. And we're talking about a country that has 28% unemployment. This is inside the European Union. But it's not just Greece. If you go to Romania, there's a massive drain of health care, the Baltic states. We're talking about countries where practically 30–40% of the European Union, where people are paying, or a large percentage of the people in the country are paying most of their medicine costs out of their pockets. Out of their pockets. And if you can't, their family members put out mortgages, they sell everything they have to pay for the cancer drug, they go on trips to India, Ukraine to try to smuggle in the medicine. This is happening, and that's why I say the chickens have come home to roost. And when we talk about, like the previous speaker said, compulsory licensing, no. And I can tell you there is serious consideration in some EU countries today of compulsory licenses for extremely expensive drugs today in the European Union. Jamie could explain it more. Okay, first of all, let me give you the beginning kind of thing, some keywords. Keywords. First keyword, affordability. Affordability. Millions of European citizens, and of course immigrants, like I spoke about immigrants. In my country, Spain, the reason, and it's the real reason of the economic crisis, was this building boom. Between 1997 and 2005, over 6 million homes, mainly tourist homes, were built on the coast. They were built mainly by immigrants, and this made fabulous profits for the people in Spain, especially the banks. Now, what has happened with the rescue operation? What has happened with the rescue operation of the European Central Bank and this and that? Has it gone to help the people who are out of work and have no medical care, who built up these millions of homes along the Spanish coast? No. Where's the money gone? Well, you know, the golden rule in politics. You know what the golden rule in politics is? Well, whoever has the gold makes the rules. Well, the money has gone to the banks. Okay. Very good. So the first word is affordability. Medicine not affordable. The second word is what we're asking for is health conditionality of rescue operations. It's a very simple thing. If 95% of the money that's going to Greece from the European Union, the Troika, IMF, do you know where that money is going? It's going to the banks. to help the financial system. What we're demanding is, why don't we set aside a little bit of that money, for health conditionality, for buying life-saving drugs? Okay. This is not happening. Not only that, it's even worse than that. And when we talk about health conditionality, let's get back to where the money is going. The Troika, or the IMF, and I can give the case of Greece, but I can speak of other countries, says, okay, you have to reduce your expenditure on drugs in Greece over 4 years from 5 billion euros to 2 billion euros. That's the objective for next year, 2 billion euros. Now, that's 60% off. Now, where does that money go today? We found out just a few weeks ago in Greece, it turns out that the public expenditure on pharmaceuticals of the Greek state, 85% of it is spent on 79 branded patented drugs. 79. These are public figures. Oh my God. So there are people being left out of the system, people are dying because they can't get the drugs, and there's 79 patented drugs, it's 85% of the public expenditure, and they have to pay prices. What prices do they pay? That's another thing people don't usually know. Does anyone know about reference prices for drugs in the European Union? This is another, what I call a zombie or the Walking Dead policy. The prices of any drug in the European Union could be a little bit higher, a little bit lower, but they have to be within the reference prices. They can't be radically lower. And this is an EU kind of policy. And what this means is that the people in Greece have to pay a price that could be a fraction, 10, 20, 30%, sometimes quite a bit less than what's paid in Denmark, sometimes. But they can't pay, for example, what's being paid for the generic drug in India or Ukraine. So that we have to say that's not very fair, and that's not health conditional. Next point, transparency in the crisis. Often we don't know, we have no idea what the prices are being paid for the drugs, because the hospitals, for example, in Spain, in my country, big public hospitals or regions of Spain have packages, and they negotiate by themselves with the drug companies what the prices are going to be. And the drug companies come up and say, okay, we're going to give you the greatest deal on these cancer drugs, on these diabetes drugs, on these HIV drugs, but these you'll have to pay. So it's a whole package. This is never published. So it's public money, but it's never published exactly how much is paid. We found out what were the prices paid for patented drugs by the state in Greece, but we don't know the individual prices paid. That makes it very, very different. Other issue about transparency. So if no one knows what we're paying exactly for the prices with public money, how could there be free competition? The other issue. Nobody really knows what the efficacy, whether the drug works or not, often. Because the issue that you all know about clinical trial data. Even though we have a very good new European law that's coming up that we fought for very strongly, that will mean that the future drugs will have to have significantly more transparency and access to that data about the efficacy or security of the drugs. But the historical data that's behind us, which is 99% of the drugs, we probably read Ben Goldacre, we don't have that information. So transparency is part of it. How can we spend our money in the middle of a crisis to get the right drug if we're not getting the information on whether it works or not, or about its safety? So that's also an important issue. Okay, the fourth point, and I think Katie explained it very well, I'm not going to go into it. Public risk, public return. 70% of the cancer research is done with public money in the US and the European Union. Where is our return? I often say that we are venture capitalists. You know what a venture capitalist is? It says, okay, I'm going to invest in wind farms in Tasmania. Oh yeah, these wind farms in Tasmania are going to make lots of money. Give me, 1 million euros, and we'll see what you get back. If it's a success, this person with the venture capitalist might get 100% profit, 50% profit. I don't know. If it goes down, it might lose everything. Well, as public taxpayers, we are risk capitalists because we're risking in scientific endeavors in thousands and thousands of research, especially in basic research. But it's half of the medical research in the world. I would say it's even more than half. Where is our return? Unfortunately, the scientific community says the return for science is excellence. The search of excellence. The return of science is how many articles you publish in so many journals. The return, even worse, is how many of your chemical substances have been patented. For them, not for us. So the public return of something that's a public good like health or scientific research, this is a very big issue. And we're fighting for that. We're fighting for that. But for example, your organization, UAEN, lobbied the European Union in Horizon 2020 to get in the rules of participation of the scientific program of the European Union, which means it's 60 or 70 billion euros. To put in the rules of participation just a general principle that the outcome of this research should be socially responsible and take into account affordable and accessible medicines. Well, this went into the negotiation. We got this approved in the European Parliament, went into the negotiations with the member states, with the ministers of health and all that, and they said, this is impossible, this wording. This has to get out. And they got it out, the member state, because they said that this kind of wording goes against the general concept of scientific curiosity and scientific freedom. Yeah, and it was pushed out. I mean, you people did a great job lobbying for this, but it was pushed out. So we could see public risk, public return is not really part of the general debate because the scientific endeavor is often mystified to only mean, and the political questions about who the knowledge belongs to, what are the social and health objectives, destiny of what you're doing and reasons, the ethical, that's not, as Bruno Latour, a famous theorist, said, they want to keep science in the cavern. They want to see it in the cavern because that way it's more easily manipulated by the politicians. But they don't want the key scientific questions to come out into the political debate and to be transparent. I'm sure John will talk more about that. The fifth point is together. Together. One of the things we're demanding in the EU health crisis is pooled procurement. If you want to bring down prices, instead of having every hospital, every region negotiating, having big pharma push some against it, why don't you just pool procurement? I'm not talking about all the drugs. When I'm talking about drugs, I'm talking about for the 15 or 20 most serious illnesses, life-saving illnesses, cancer drugs, HIV drugs, things like that really save people, hepatitis C, that are very expensive and save people's lives. Why don't we pool procurement? We'll have a lot more power in negotiating. This is like a taboo question. It can't be done. It's even seen as a threat by the European Commission against competition. They said it goes against the internal market laws. Because, as the first speaker spoke, this idea that we have to pay very high prices for drugs in Europe for the trickle down to go into innovation or research, or the trickle down for them out of the goodness of their hearts to give some special deals to the poor people, that's the basis of the system. Okay, so together. The sixth point would be justice. That's about immigrants and other vulnerable groups. We say we use immigrants for cheap labor, and then we want to throw them out when financial times come around, like it's been done in Spain and so many other countries. In Greece, you see thousands and thousands, and also in Spain and other countries. In Greece, you see them on the street, and they're receiving violence, they're receiving all kinds of things, threats, and they're being blamed for crisis which they didn't cause. And the first thing that is happening to them is they're not being treated. In Spain, they can only get emergency care. I think in Greece, no care at all. No care at all. And in many other countries, immigrants are bearing the brunt of this healthcare crisis. Where are our basic values? I mentioned, I won't go on, I'm just going to say the title, Public Knowledge Goods. We would like what's generated with public funds to be openly accessible. We have made progress. In Horizon 2020, there's going to be a mandatory obligation, we'll see how it's going to be applied, for open access publishing. It has some difficulty, and I'm not going to go into that now. Which means that publicly financed research, much of it is medical research, after a moratorium period of, let's say, 6 months, could be 12 months, it has to be publicly accessible online, free of charge. All of these academic articles. And this is a big advancement. I'm not going to go into the details, it's too much, not that. There is also what we got into the new EU law on research and development, open data. Open data. This means that not just the scientific articles, but the data that is generated with EU funding must be accessible for people to use. And this is tremendously important for medical research in things like data mining, I mean, other people use it, and for scouring thousands of articles at the same time and databases at the same time. And this, we got the promotion of this into the EU law. And this is a big tendency, and it's also very important. So these are public knowledge goods, but I think we have to go way, way beyond that so that we could get products produced, generic products produced for low-cost medicine from the first day, not having to wait so much. The eighth point are tricks and bribes and pay to delay. I have to say, I didn't tell our first speaker, Mr. Jacob, Sir Jacob? Sorry. He said something that was really outrageous, I have to say it. He said that it fizzled out the accusation, he referred to the European Commission study of how pharma companies pay their generic competitors not to bring out generic products when the patent runs out. It's called pay to delay. I call it bribes. And this has happened in the United States, according to the study of, I think, of the FDA, and it's happened in 200 cases documented in front of everyone's eyes by the European Commission. I was there when they presented the report. And the pharmaceutical industry admitted it. And we have someone come here and say that that isn't true, when everyone in the world has admitted it. So I'm pretty flabbergasted. That means, as European public health services, we have had to pay, it was, I don't know, it was 15 or 20 billion euros more fraudulently after patents had run out because they're paying off generic companies. Well, you take these millions not to bring out a cheaper medicine. It's like, it's pretty tough. Now, he was right, he said, this fizzled out. Why did it fizzle out? Because instead of taking this to court and making this into a giant suit to sue the pharmaceutical companies from the European Commission, it was put into a drawer under the pressure of the German and the French governments, who have big pharmaceutical companies, who didn't want to take them forward. So that's, but there are many other tricks and bribes and paying doctors and all these things. Okay, that's the eighth one. The ninth one is the industry myths. I'm not going to go into that, but it's talking about how much it costs. I think the idea that and Jamie has explained this very, very well in other talks. And the pharmaceutical industry has thousands and thousands of research things, and only less than 1% turns into medicine. So it's such a tremendous risk. That's why it's not true. And Jamie he presented the data in Brussels last year, saying 12% of the research that reaches the research stage, especially clinical trials, become authorized medicine, which is, I mean, it's small, but it's pretty big. It's pretty big, 12%. Okay. I'm going to leave this to Jamie afterwards, and then I'm going to talk about some of the political contradictions. Then, the last point, number 9 was industry myths. Number 10 was delinkage. Katie's spoken about it. I think Jamie, that's his title, so I won't go into that, but the delinkage are new innovation models, project development, patent pooling, prizes, equitable licensing, and other things like that. But I won't go into that. Let's talk a bit about what's happening and what our problems are. Why are we kind of hitting ourselves up against the wall for what's happening? On the European agenda, we have had some successes like the clinical trial regulation towards transparency. We have had Horizon 2020, like I've mentioned, but we've also have some tremendous challenges. How many of you have heard of the EU-US Free Trade Agreement? Okay. Last week, at a stakeholders meeting held by the European Commission, the person responsible for negotiating pharmaceuticals said, one of the issues we're most intensely negotiating with our US partners are pharmaceuticals. And rest assured, this is the European Commission, that rest assured that we have the pharmaceutical industry wish list present at the negotiating table. How many of you know what the pharmaceutical industry wish list is? Well, actually, luckily it's been leaked. I don't know if it was I think it was WikiLeaks, I don't know. Jamie, do you know who leaked the pharmaceutical company wish list for the TTIP negotiations? Was that WikiLeaks as well? I don't know who leaked it. Someone leaked it recently. And this wish list, I have it here for any of you who need it. It has all the issues we're talking about now, about patent extension, compensation, data exclusivity, which means they're not going to allow this effectively extends a patent because they don't allow all of the data that was accumulated in clinical trials about the chemical compounds to be used, so the generics just can't bring out a generic, even if the patent has run out for it. And many, many other issues about secrecy. They want commercial secrecy on the data. And this is the joint demands of the European and the US pharmaceutical industry to put into law of the EU-US Free Trade Agreement that would actually be above the laws and would have to be applied both in the US and the EU. Why? Why? Because one of the main elements of the EU-US Free Trade Agreement is the investor-state dispute mechanism, which means that if your investments are put into danger and not secure, you could challenge any law that's going on on either side of the Atlantic, and that's happening even today. For example, Canada's laws on not allowing a new patent on a drug. You know about that case, Jamie? I'm not very well. Canada's law, I think, that's being challenged. That's being challenged by Lilly case, right? Well, this mechanism that allows you to challenge a state law or any state court by the pharmaceutical industry could come into effect in this EU-US Free Trade Agreement. So we have some very strong challenge, but our opposition has been so strong on this that just this week the EU Trade Commissioner said, because we've had massive opposition to this, well, let's reevaluate this, and we're going to have a public consultation about this, and which all of you can participate, of the European Union about the EU-US Free Trade Agreement and the investor-state dispute mechanism. And I will let you know about that so you could write in your opinions about that, because they'll need lots of opinions. Okay, let's get on to some of the contradictions and some self-criticism. What are our contradictions and weaknesses? There are many. There are very many. First of all, we have a double discourse often among, let's say, the progressive community. The double discourse is this. This morning I was chatting with my nephew who's on a herbal medicine farm in Tasmania, raising herbal medicines. And he was asking what I was doing. I told him I was coming here to the conference on access to medicines. And he said, yeah, well, and I told him, yeah, I said, many medicines are crap, but some save millions of lives. He said, you're telling me I'm a diabetic. That's what he told me. And I think this is one of the contradictions of our discourse as well. In the rich world, 90% of the medicines are either the same or worse, or they're overly prescribed, overdiagnosed, 90%, to make tons of money. That's why the US is the buyer of over 50% of the medicines in the world, but their health standards are 51st out of all the other countries. Anyway, so this is similar to the debate about, there are many, many people who are fat and overweight in much of the world, and this is alongside millions who are going hungry. But it makes it kind of difficult to combine the interest in rational use with access to affordable medicines. I think this is very important. For me, it's two sides of the same coin. We're talking about an innovation system that's just about making money and creating false illusions about solving every kind of psychological, personal, and physical problem that often can be solved in another way. And that's how they make lots of their money. Whereas the pharmaceutical industry should be focusing on health-driven solutions to what are really making people sick and killing them all over the world. And that's not happening. But that's still a contradiction in a narrative we've had. The second one, and this is really true, and I think Katie has said, we're really good at smashing big pharma, but we're not very good at showing alternatives. And that's, we have all this good negative criticism. We don't even need to do negative criticism. We just need to let them talk themselves and they make it go. But we haven't shown a new way in practice of incentives for medical bio-innovation not controlled by patent monopolies. Now, why this has happened, how this has happened, why we're not successful at the World Health Organization, why we're not successful in the EU, also is because They have thousands and thousands and thousands of lobbyists and millions of people working for them, including, the first speaker has worked for them as a lawyer. So, and it's very difficult. How many public health advocates are lobbying the European institutions? I don't think it's more than 5 in Brussels. Not more than 5. I mean, on a full-time basis. And how many lobbyists, directly or indirectly, work for the pharmaceutical industry in Brussels? Over 3,000. I don't know how many work for the pharmaceutical industry in Washington, but I'm sure it's in the thousands as well.
2 for every senator.
Sorry?
2 for every senator.
Oh, but do they live in the senator's office? Okay. Now the third contradiction, and this is a real key one, is that, I said, rich people need to pay a lot for big pharma to give a break to the poor. And this comes out, and this is a very key thing that they've always been pushed on, tiered pricing. Tiered pricing. So we're going to give a break to the poor as long as the rich, I insist the rich is a zombie term, the rich are the unemployed in Greece. The rich are the unemployed in Greece. Because when we speak of rich, and the middle income countries are the people living in rubble with nothing in Syria. These are the middle income countries. Now, I'm not being demagogue. That's how it works. These are the categories on an international scale for establishing tier pricing. And someone told me, and I won't give it, that one of the problems that millions of children in Syria are not getting vaccinated is because the pharmaceutical companies say that Syria, even today, is a middle-income country, and they can't give them a break, and they have to charge them 15 times more than the cost of the vaccination to give this NGO the vaccination, so these people, the children won't get polio and all these horrible diseases in Syria. And that's happening right now. Right now. Negotiations with Glaxo and others. And that's not only that's a Syria problem, and they've been insisting, 2 years of negotiation. They haven't come down from 15 euros when the vaccination cost them less than €1 for the children of Syria. How can that be? How can that be? It's a moral outrage. Now, it's not just a moral outrage there, because in Greece today, 1/3 of the children are not being vaccinated, and because of corruption with the pharmaceutical industry towards the doctors, especially corruption with doctors, they charge over 1,000 euros to put a child through the 2-year vaccination, up to 1,500 euros, the 2-year vaccination. We have all this data, for example, on the island of Crete. So, this is happening, as I say, the chickens have come home to roost there. So we're talking about, and tiered pricing is seen as the solution. This means, well, let's just establish, 20, 30% cheaper for the poor people. This does not work. And if you have an expensive cancer drug, taking off 20, 30, 40% is still extremely expensive and impossible for most of the world's population to pay, and for the poor in Europe to pay as well. So tiered pricing is not as, and it also means that it comes out of the goodness of the heart of the pharmaceutical company. It's not based on justice. It's not based on a market solution. It's based on a voluntary, and I'm sure many people like Jamie, Katie, very good arguments of why tiered pricing is not working. And it's not going to work in the European Union either. So, is that justice? Is that what we want? So the EU is based on principles. I know, and I didn't want to give the false statement. The European Union is not competent for healthcare in the countries. Obviously not, because the healthcare doesn't come out of the EU budget. Nevertheless, the EU does today mandate to countries like Spain and to Greece and to others, you must reduce your health budget by half or more than half if you want to get bailout money. So this means some very, very hard questions. And it's hard questions not just about the crisis, because some people would say, okay, when we get through the financial crisis and people are booming and Spain is selling their holiday homes again in Marbella, everyone will be happy. No. It does not work. Every single econometric study that is done, I think Jamie did one, on cancer, for example, expenditures for public health systems in the European Union makes it impossible to pay for the most advanced cancer drugs for people over the next 5, 10, 20, 25 years. It's impossible. There's no way. And even with health budgets going up little by little, There's no way that's going to happen. So we have to have a new way of paying for these drugs. We have to have a new way of healthcare, and there has to be a new innovation model. There has to be more justice. There has to be more inclusion. When I talk about justice, it's not just about EU citizens. How many of you have heard of Chagas disease? Who knows what European country has tens of thousands of cases of Chagas disease?
Spain?
Spain, because of all the Peruvian and Ecuadorian immigrants. And they have been excluded from the healthcare system, and they're not getting treatment. This is a scandal. This is an absolute scandal. And often there have to be NGOs like MSF or Médecins du Monde, Doctors of the World, who are giving this treatment on the street or in clinics. And this is ridiculous because with this illness and many other illnesses, by not treating immigrants, it's actually more expensive. More expensive for the health system because there's more people can get the illness, but also, especially since the treatment is only given on emergency scale in a hospital when people are almost dead, that's much more expensive than treating people more preventively. And so it's incredible that millions of immigrants are being excluded from healthcare all over Europe. And even EU citizens have been excluded historically, like Roma people, Gypsies, people like that. Aside from the EU citizens, where there are also millions who are excluded just because they're very poor, they're unemployed, or whatever. So I think the chickens have come home to roost, and the whole system is in crisis, and we can't expect the rich, the so-called rich, to pay for the poor, even inside the European Union, and we need to find a better way, and that's what Jamie and John will be telling you after lunch. Thank you.
We've only got time for one or two questions. Does anybody want to raise one urgently? Yes?
Hello. I don't know if this is overly naive, but
Nothing is over.
Okay, yeah, thank you, great. Aside from pressure strategies, are there ideas for how you politically incentivize movement towards better access strategies?
Yeah, I mean, what I'm doing here is part of that. What we're trying to do is to build a bridge. This is not just about an AIDS patient in Botswana. This is about people, who are much closer to us in our political sphere. It might not be family members, but people who are near us. So that's one thing. We have a common interest. There's a common interest to change this type of model. That's one. Then I think we're not very good at selling what we're saying. We're very bad. And I think we need PR people, we need specialists. We did a campaign, had nothing to do with this, for example, for changing intellectual property rules for blind people having access to culture, as copyright, not patent, all over the world. And we were able to create a pretty good campaign with the help of people like Stevie Wonder and others. But I think with the campaign we have here, and MSF, you do great campaigns, but I think we also have to have a new way of message, and we need to make a political majority. This is a power game. This is a big power game. Unless they see their losses in legitimacy, their losses in public relations, their losses in the big pharma company, they're not going to want to change. And I think we also have to use the arguments of the taxpayer. That, for example, the guy who spoke where said, public money will never do this. No, we have to turn that argument on its head and say, wait, we're taxpayers. We already paid for this. Why are we paying again? And people don't know about that.
Can I ask a follow-up question? Do you think this is quite pragmatic and maybe cynical, but one of the points is that when UAM or anyone else says don't enforce generics in developing countries, one of the ripostes is, but you think this is only a problem in developing countries? Look at all the poor people in the US. Look at all the things you're talking about. The problem is poverty. We should tackle poverty. Don't touch patents. So do you think it is possible to reconcile those two?
No. That's a tautology. In the U.S., there are Jamie. So I'm going to pick your brain. You're the only U.S. person here. How many people suffer from illness, poverty because they get sick? I mean, there's lots of people in the U.S. How many people are poor because some member of their family, someone gets sick? in the US? Is there any figures on that? It's tons of people, no?
I think
I don't know, but like, I mean, I think there's all kinds of consequences of you know, high prices. And one would be people who don't have insurance, and there's always people in every country that don't have insurance. Even in a country that has a pretty robust policy, they may have people that are there working, undocumented workers and things like that. And then you've got cases like the United States where it's trying to introduce obligations for insurance, but you know, the system is sort of not that robust. There's still.
But what I'm saying is one of the main causes of poverty in the U.S. is there's a name for it. It's called medical poverty, and there's like a big percentage of people are in medical poverty because of their illnesses. Not only that, it's kind of like they put it on a futures market. Someone explained this to me, where the debt, and it's like affects millions of people in the U.S. The debt of the people from medical poverty is put on a futures market. So, okay, we will sell you this debt for 20% of what it's worth because they can't get the people to pay them back. So these people then, you know, the people who buy the medical debt, if they get back that debt, it's over 20% is their profit. Anyways, but I'm saying it's a big problem. So when someone says causes poverty, it's the opposite. One of the reasons of poverty is the high price. It's a total tautology. Yeah, Katie.
I just think that there's something very interesting about this argument of poverty that I would encourage people to look at, which is, I don't know how many of you saw last week that the pharmaceutical industry in South Africa, IPSA, a document was leaked that showed their strategy how they're going to prevent South Africa from changing its IP law to make it its intellectual property law in order to make it more, to incorporate the TRIPS flexibilities and make generics more widely available. And when you read that document, it's only a 12-page document, and you can find it on the Mail and Guardian's website. They've actually uploaded it. What they say in there is our primary target is the NGOs. We need to set them back on their heels and stop them in their own aggressive campaign. And they say, but whatever happens, we need to avoid this becoming a debate about the high price of medicines at all costs. We need to make this a debate about poverty. We need to fund all these different opinion leaders and to write articles and to hold conferences saying that the problem is not the high cost of medicines, the problem is poverty. And I think it's very, very useful for us to look at that because that is the industry's document leaked from the industry showing their tactic, which is let's not talk about the high cost of medicine, let's just make this a lot more diffuse and a lot harder to deal with which is it's all just about poverty. Until we overcome poverty, we can't address any of these problems. And we have to be aware of that. This is the way they want to spin the debate. They do not want to talk about pricing, they want to talk about poverty.
But Katie, that has a very simple response. Two wrongs don't make a right. And obviously, without healthcare, without clean water, all these things. But they said that about the AIDS drugs. Those of you who've seen, for example, the film Fire in the Blood, we have one of the movie stars there sitting in the back. In Fire in the Blood, that's what the big pharma said about giving lower prices for AIDS drugs in Africa. They said, well, it won't do any good because they don't have to. Well, the number of deaths went down radically by bringing down the price. So, obviously, you could say, it's like saying, until women have a higher standard of living, we're not going to bring down birth rates. So they don't need contraceptives. I mean, it's a really pretty stupid argument because it's like saying, oh, since Hurricane Sandy is worse than whatever, what's the use of doing having health care there because Hurricane Sandy's going to kill them anyways. I mean, it doesn't make any sense. It just doesn't make any sense. It's absurd.
We've got to have something.
Well, they have to have something. What I'm worried about that argument is not from the pharma companies, but from so-called leftists who use that argument. And the so-called leftists say, it basically, until we have the revolution, nothing's going to happen. And it's all about capitalism, blah, blah. And then they don't get into the nitty-gritty of what's in the process of innovation and pricing, all this, that's hurting people. And that also hurts they're almost allies of big pharma in that sense because they're macro-structural and don't get into the micro. Yeah, but anyways, that's any more questions?
Well, just a follow-up discussion point for what you're just saying. That was the interesting thing about the talk this morning was that it was very concerned with just the patent system rather than what necessitates the patent system, or well, necessitates the patent system. But I mean, what's interesting is that you're speaking on a much broader scale in terms of the, as you say, the nitty-gritty. Why is the patent system justified? Why are those arguments accepted? And so by dealing with that side of things, you can actually completely undermine any well, reasonable justification for the patent system just by getting involved in that.
Yes, but in a way what we say is counterintuitive. Because this idea that the more private something is, the more protected something is, the more secret something is, the more incentive for innovation there will be. And this idea is kind of intuitive, and what we say is counterintuitive in that sense. But obviously the patent system in reality has failed. There's no more, we all know it's failed. And obviously there are patent thickets. There are tons of patent thickets and patent trolls and lots of other monsters.
Oh, so they do exist?
Okay, thank you, and I think you guys are doing great jobs. It's very inspiring for me to see what UAM is doing, and it kind of cheers up my spirits, like when I went to a conference last April in Copenhagen, and I think that there are young people like you and universities fighting for these things. I think it gives us all hope. Thank you very much.